Good day, everyone. Welcome back to my channel. If you are new here, welcome. If not, welcome back. This video, we're going to be talking about all the important words and terms that you need to know for oral pathology. Yes, there are hundreds of terms that you need to know, but these here are the most important and some of the most tested words that you're going to get in your class. Granted, if you're in South Florida, if you're in Georgia, if you are in New York, if you're in California, whatever, these are the terms that are the most common, and these are the terms that you are mostly going to hear when you are studying oral pathology. I'm going to go by this deck fast because these professors, they don't care. They're here to just collect their check and go home, if you ask me. But that's besides the point. Anyway, let's get right into this video. First word, bulla. A circumcised elevated lesion that is more than 5 millimeters in diameter usually contains serous fluid and looks like a blister. Lobule. Segment or lobe that is part of a whole. These lobes sometimes appear fused together. Macule. An area that is usually distinguished by a color different from that of the surrounding tissue. It is and does not protrude above the surface of the normal tissue. A freckle is an example. Papule. A small circumcised lesion, usually less than 1 centimeter in diameter, that is elevated or protrudes above the surface of normal surrounding tissue. Pedunculated. Attached by a stem-like stalk, like base similar to that of a mushroom. Pedunculated. Pustules. Varices-sized circumcised elevations containing pus. Sessile. Describing the base of a lesion that is flat or broad instead of stem-like. Vesicle. A small elevated lesion less than 2 centimeters in diameter that contains serous fluid. Nodule. A papule solid lesion up to 1 centimeter in diameter found in soft tissue. It can occur above, level with, or beneath the skin surface. Palpation. The elevation of a lesion by feeling it with the fingers to determine the texture of the area. Erythema. An abnormal redness of the mucosa or gingiva. Erythroplakia. A clinical term used to describe an oral mucosal lesion that appears as a smooth red patch or granular red and velvety patch. Leukoplakia. A clinical term for a white plaque-like lesion on the oral mucosa that cannot be rubbed off or diagnosed as a specific disease. Pallor. Paleness of the skin or mucosal tissues. Corrugated. Wrinkled. Fissure. A cleft or groove, normally normal or otherwise showing permanent or prominent depth. Papillary. Resembling small nipple-shaped projections or elevations found in clusters. Smooth, rough, or folded. Terms used to describe the surface texture of a lesion. Coalescence. The process by which parts of a whole join together or fuse to make one. Diffuse. Describes a lesion with borders that are not well defined, making it impossible to detect the exact parameters of the lesion. This may make treatment more difficult and, depending on the biopsy results, more radical. Multiocular. Describes a lesion that extends beyond the confines of one distinct area and is defined as many lobes or parts that are somewhat fused together, making up the entire lesion. Radiolucent. Describes the black or dark areas on a radiograph. Radio energy can pass through these structures. Radiopaque. Describes the light or white area on a radiograph that results from the inability of radio energy to pass through the structure. The denser the structure, the lighter or whiter it appears on the radiograph. Root resorption. Observed radiographically when the apex of the tooth appears shortened or blunted and irregularly shaped, occurs as a response to stimuli which can include a cyst, tumor, or trauma. Scalloping around the root. A radiolucent lesion that extends between the roots, as seen in a traumatic bone cyst. Uniocular, having one compartment or unit that is well defined or outlined, as in a simple radicular cyst. Remember, only means one, so that's why it only have one compartment. Well circumscribed. Term used to describe a lesion with borders that are specifically defined and in which one can clearly see the exact margins and extent. Dysphagia, difficulty swallowing. Dysphonia, difficulty speaking. Dyspnea, difficulty breathing. The 8 categories that contribute segments of information leading to the definitive or final diagnosis. This one here is the cream of the crop for this video. If you're still watching, thank you so much. This is the bread and butter of oral pathology class. All right, let's go. 1. Clinical. 2. Radiographic. 3. Historical. 4. Laboratory. 5. Microscopic. 6. Surgical. 7. Therapeutic. 8. Differential findings. Once again, please, guys, please write this down. 1. Clinical. 2. Radiographic. 3. Historical. 4. Laboratory. 5. Microscopic. 6. Surgical. 7. Therapeutic. 8. Differential findings. All right, number 1. Clinical diagnosis. Suggests that the strength of diagnosis comes from the clinical appearance of the lesion. A clinician can establish a diagnosis for some lesions on the basis of color, shape, location, and history of the lesion. When a diagnosis can be made on the basis of these unique clinical features, biopsy or surgical intervention is not necessary. Radiographic diagnosis. A radiograph provides the sufficient information to establish the diagnosis. Although additional clinical and historical information may contribute, the diagnosis is obtained from the radiograph. Historical diagnosis. Historical data constitutes an important component in every diagnosis. Occasionally, when historical data are compromised with observation of the clinical appearance of the lesion, the historical information constitutes the most important contribution to the diagnostic process. Laboratory diagnosis. Clinical laboratory tests, including blood chemistries and urinalysis, can provide information that contributes to a diagnosis. Surgical diagnosis. A diagnosis is made using the information gained during surgical procedure. Microscopic diagnosis. The microscopic examination of the biopsy specimen via scalpel biopsy taken from the lesion in question contributes significant information. This procedure is often the main component of the definitive diagnosis. So once again, sorry for the noise. The microscopic examination of the biopsy specimen via scalpel biopsy taken from the lesion in question contributes significant information. This procedure is often the main component of the definitive diagnosis. Therapeutic diagnosis. Nutritional deficiencies are common conditions to be diagnosed by therapeutic means. A thorough patient history should be obtained to rule out a contributory nutritional deficiency. Differential diagnosis. That point in the diagnostic process when the practitioner decides which test or procedure is required to rule out the conditions originally suspected and to establish the definitive and final diagnosis. All components are applied to this one. Okay, there you go. For size granules is to continue. Clusters of ectopic sebaceous glands, most commonly observed on the lips and buccal mucosa. Clinically, they appear as tiny yellow papules in clusters and are usually distributed over the buccal mucosa or vermilion border of the involved lips. Torus palatinus. An example of extosis, it is an ectopic growth. It's an exophilic growth of normal compact bone. It is benign. Palatal tori occurs more frequently in women 2 to 1. They are more common in Asians, Native Americans, and the Inuit. Mandibular tori, outgrowths or normal dense bone found in the lingual aspect of the mandible in the area of the premolars above the mylohyoid ridge. Melanin pigmentation, the most commonly observed in dark-skinned individuals. Really, that's all they have to say about melanin, but I guess. Retrocuspid papilla, a sessile papilla found on the gingival margin of the lingual aspect of the mandibular cusp. Lingual velocities, permanent lingual veins usually observed on the ventral and lateral surfaces of the tongue. Linea alba, a white line that extends anterior-posteriorly on the buccal mucosa along the occlusal plane. It may be bilateral and can be more prominent in patients who have a clenching or black bruxing habit. Leukoedema, a generalized opalescence is imparted to the buccal mucosa, most commonly observed in black adults. Lingual thyroid, when thyroid tissue either does not descend or remnants become entrapped in the tissue that makes up the tongue. Clinical symptoms can include dysphagia, dysphonia, and dyspnea. Median rhomboid glossitis or central papillary atrophy. Clinically, median rhomboid glossitis appears as a at or slightly raised oval or rectangular erythematous area in the middle of the dorsal surface of the tongue. The cause is not clear. Erythema migrans, usually asymptomatic and discovered by the dental hygienist or dentist on a routine or mucosa examination. Diffuse areas devoid of filiform papillae can be observed. Fissure tongue. Clinically, the dorsal surface of the tongue appears to have deep fissures or grooves from 2 to 6 millimeters that may become irritated if food debris collects in them. Diagnosis based on appearance. The cause is unknown. A hairy tongue, a condition in which the patient has an increased accumulation of keratin or the filiform papillae that results in a white or hairy appearance. Black hairy tongue, the papillae are brown to black color because of chromogenic bacteria. Tobacco and certain foods discolor the papillae. All right, and that is the last term for today's video. Please review these terms, know these terms, especially if you're just starting a class, if you're not even in the program yet, but you've been accepted. These are the terms that you need to know. Get familiar with these terms, know them like the back of your hand. You're gonna hear these all throughout the class and even all throughout the program. Thank you guys for watching all the way until the end. I love you guys so much. Don't forget to like, comment, and subscribe. And I'll see you guys in the next video. Take care. Have a good one.